record on this computer. And admitting.
Okay. So I guess we'll give like a few minutes for everyone sort of come on in. Oh, you did do, I think this is the unedited one. Do you think you could send me your edited one?
Yeah. Yeah, it was just like minor things. So which one should I send it to? The SOM or just a regular Geisinger?
He's the regular guy singer girl.
Okay. Did it go through? So if not, I could share it. You could just tell me when to go to the next slide.
Yeah, sure. All right.
Can everyone see that?
Yeah, looks good.
Okay.
So let's get the party started then. So very nice to meet everyone. Just as an FYI, you coming to this lecture, you will be recorded. So welcome to Geisinger's Bold ERG partnership with BSPCAC and NAACP Wilkes-Barre for the Black Men's Health Matters. Is created by Geisinger's Bold and the Education Subcommittee, which includes Priscilla, Faith, and Tamara, including and also the fabulous Vicky Sam. Next slide, thank you. I will be the moderator. Hi, I'm Dr. Daryl McBride, infectious disease physician, and I'm also the co-chair of BOLD. Next slide. Thank you again very much to the Executive Bold members, Arthur Breeze, Brian Lieberman, Michelle Antle, and support and marketing team, Heather Davis, Liz, and Annalise. Next slide. So we have a few more things left to go. We have on Tuesday, the 22nd, we have racial and ethnic disparities related to child and adolescent healthcare by Dr. Howard. And then on Tuesday, the 29th, at noon, we have Cancer in Black Men, Disparities in Science with Dr. Wilkins. We are continuing our journal club, which I have personally been enjoying. So we have Les the 22nd from 5 to 6, the 29th from 5 to 6, and July 6th from 5 to 6. Next slide. So this is just some overview about BOLD. We embrace culture of inclusion. We build awareness and appreciation for diversity, and we foster those things across the entire diaspora of Black and African American culture, Afro-Caribbean, Afro-Latinx, et cetera. We ask all BOLD members to join a subcommittee or ad hoc if possible. Next slide. And here are some of the people you can reach out to in order to get involved with some of Geisinger's ERGs. BOLD, clearly me, Vicky, Arthur or Brian Lieberman again, Women's Lead, G-Pride, VNet, and GAIN. Next slide. We're also having a Geisinger's BOLD ERG giveaway, so please scan the QR code to enter the drawing. Next slide. And I will be highlighting some untold stories. Next slide. Spotlights. So next slide. So we went over Dr. Tuckson June 1st. Next slide. We went over Dr. Vicker. Next slide. Went over Dr. Mighty. Next slide. We've gone over Dr. Carlisle. Next slide. And today I will go over Dr. Owusu Akia. So he is the orthopedic surgeon with a focus on sports medicine. He is the co-founder of the Coalition of Black Physicians at Duke. He has published in several journals and has authored a few books as well. He currently serves as a company physician for the Richmond Ballet. He's a team physician for Life Christian Academy, and as a consulting physician for 804 sports associations and Defy Genetics. We celebrate you, sir, and on to introduce the speaker, Ms. Priscilla Cabral. Thank you so much.
Sorry, it took me a second to come off mute. Hi, everyone. I'll be introducing the speaker tonight. I've been to BOLD events. My name is Priscilla. I'm part of the BOLD resource group here and the co-chair of the education subcommittee. I have the pleasure of introducing our speaker.
Yeah, the next one.
There we go. Mr. Clay Jacobs. We have a quote to start off, which is, doing is a quantum leap from imagining. Clay Jacobs has the incredible opportunity to connect talented, passionate people and help them work together to achieve greater impact towards the association's vision of a world without Alzheimer's and all other dementias. As executive director for the Alzheimer's Association, Greater Pennsylvania chapter, this means working with staff, volunteers, and partner organizations to translate organizational vision into reality across 59 of the 67 counties in Pennsylvania. By working with staff, volunteers, organizations, and others, Clay's focus is on supporting and engaging research, driving risk reduction and early detection, and maximizing quality care and support through public and private policy advancement. Under his leadership, the Greater Pennsylvania chapter has been one of the premier chapters of the association, consistently achieving results in the top 10% nationwide for care and support, concern and awareness, and public policy. All supported by the #7 largest Walk to End Alzheimer's program in the country. Clayton has previously served as a member of the PA State Alzheimer's Disease Task Force and on Penn State Health's Community Research Advisory Board, and currently serves on the Pennsylvania Department of Aging, Diversity, and Inclusion Council, America 250 PA Advisory Council, and numerous nationwide Alzheimer's Association work groups, including those focused on strategic planning, health system engagement, and building community boards for excellence. Right. I'm glad to introduce Mr. Clay Jacobs, and I'll stop sharing so you can share your slides.
Mr. Jacobs will be talking about Alzheimer's disease in our community.
And thank you, Priscilla. Thank you, Dr. McBride, and kudos too. I'm not sure how we got that to you, but I will say that lengthy explanation will be the high point. I feel like I have a lot to live up to just based on the volume of things we shared. But really glad to be with everyone tonight. In my role as I have the privilege of serving as the executive director for our chapter, which covers 59 of the 67 counties in Pennsylvania, really everything but the Philadelphia market, which is served by another chapter. And particularly excited to be with you due to my connection to Northeast PA. And so as we were coming on, I was sharing with Priscilla and Dr. Sapp that really I've lived a large chunk of my life in Northeast PA outside of Scranton, and visiting. Both my parents are from the area, graduated from West Side and Central High School, and have lived there for years, and also feel a deep connection to the community with my great-grandfather serving as pastor for Bethel AME once upon a time, and that being our family church. My wife graduating from Marywood, and even right now, she actually works for Geisinger. And so I live in Harrisburg, PA, but we have connections to each of you in this work. And so I'm excited to be here because this is an important conversation, and we have at least my prepared points the next half hour, 35, 40 minutes to share a little bit about Alzheimer's disease, what's going on right now, what are some of the considerations, and then be able to answer questions. But what I'd really encourage as we go through is some of these are complicated topics. We all have different levels of understanding. And quite frankly, right now is an exciting time in this work where there's a lot of new things happening. And so we'll talk about some of that, but certainly don't hesitate to, I'll prompt throughout times. You can feel free to drop questions in the chat, which Priscilla can share, and really as much as we can make this a conversation. And I think it's important to make it that way because Alzheimer's disease often can seem insurmountable, right? Even if we look at strictly from a family perspective, the person we know and love and care about is changing. But around that person are their families, their workplace, their faith community, their neighborhood, all of these things. And so while Alzheimer's disease and other dementias can certainly be an isolating condition, by its very nature, it's one that impacts communities. And ultimately, I firmly believe that the only way we make a difference is through community as well. And that may be towards a cure as we look at the research community, and maybe around care and support as we look at our communities, the medical community as we improve on early detection and diagnosis, but all of these things. And so that's the context for today's discussion. And my hope today is that we touch on a few of these things. Not knowing people's perspectives as they join, we are going to spend a little time just really clarifying Alzheimer's disease and other dementias, what those terms mean, what they look like, and how our understanding has changed even in the past recent years. And we're going to highlight some of the things on how Alzheimer's disease and related dementias. And so if you see that, I apologize. Every industry has acronyms. ADRD is Alzheimer's disease and related disorders or related dementias. We're going to talk about that on the African-American community and some of the potential considerations. We're going to share some of the resources that are available and how communities can get involved. And then we'll talk not nearly to the amount of time that we could, but around how health disparities specifically impact in the Alzheimer's disease space and some of the things happening right now to try and address that. And so that is a lot to try and get in. Hopefully we'll give enough that there are a couple of pieces you take away from today that spark your interest, that help you better connect, and all of those things. As we start that, you certainly heard at the beginning a little bit about the Alzheimer's Association, but ultimately, we're an organization that unless people need us, often they don't know about us. And so I think it's important to start with a little bit of background on who we are. Ultimately, the Alzheimer's Association is a global organization working to advance care, support, and research across the world. And when we'll talk about some of the things going on in Pennsylvania, part of the benefit of our work is that it is truly global. Right now, as we speak, researchers funded by the association are at work. And that is true 24 hours a day, 7 days a week. Our care and support services are available. And ultimately, it's that blend of people and science. And so as you look at the screen, even if you ever see that symbol, that's what it is. We have that profile of a person and that Erlenmeyer flask. At times folks will consider it a beaker, but those who are into it as well, as we look at that terminology, but that is our work. And when we look at this disease, I mentioned earlier how it can feel isolating, and ultimately we see social connects and other things changing. But a couple of years ago, New England Journal of Medicine identified it as the most expensive disease in America and the largest public health crisis of our age. Now, certainly that was prior to the past year in COVID, but actually it's a great example of something that has incredible impact, that when we put resources and public health approaches to, we can make a difference. And that's a lot of the context of when we talk about Alzheimer's disease. Right now, there are more than 5 million Americans living with the disease, and 1 in 3 seniors are dying with dementia. We know that millions, and you can see the numbers on the screen, are providing unpaid care. And in Pennsylvania, those numbers are just as significant. We have 280,000 people today just with an Alzheimer's disease diagnosis. That's expected to increase to 320,000 just by 2025. And again, that is with a diagnosis, never mind those with mild cognitive impairment or other dementias, or who just haven't received a diagnosis as of yet. And I think that's important because as we look at that component and we talk about health disparities and access to care and other things, Medicare and Medicaid services actually did surveying a couple of years ago and identified that the disclosure rate for Alzheimer's disease, so we're diagnosed, we have probable Alzheimer's disease, the disclosure rate is less than 50%. It's around 45%. So even when a diagnosis is made, the conversation with the patient and family, something that is still lacking. In fact, it's very similar to the same type of surveying done in the mid-70s with cancer. And we highlight that as we look at one of the figures on the slide, that 50% of primary care physicians believe that the profession is not equipped for the growing number of people, where we expect exponential increases as our population ages. And ultimately, when we look at the costs and other components to it, that's why there's such a need to address it now. And ultimately, when we talk about costs, it's not only about financial, but it's about the emotional and personal. Right? As we said, this is a disease that impacts communities and families of choice. And so it's important when we start to really be clear about what some of these terms and language is. And so I know we were trying to get it together. We might have a poll question here, really related to one of the most common misconceptions. And so what I'd ask of folks, and feel free if we're able to pop in the poll or share in the chat, whether from your understanding, is dementia a normal part of aging? And so I lift that up because that is one of the most common misconceptions. So there's the poll. We'll give a few seconds for folks to answer. And so it isn't, right? It is not a normal part of aging. And ultimately, in and of itself, it's not a diagnosis. Dementia is a syndrome. It's a collection of symptoms related to cognitive decline. And ultimately, it's that these things have progressed to an extent that they're interfering with daily life, right? It's that we've had cognitive changes, behavioral, psychological changes that interfere with daily life. Whereas normal aging might have some impact, but we're still able to go about our daily lives. And so often when families are considering, what is going on, it's this idea of the quantity and quality. How are things increasing? How severe are they getting? And ultimately, it's due to biological changes of the brain, which is one of the most difficult things to understand. We see the person changing, and unlike other diseases, we don't readily have available the ways to see the underlying biology or the rationale for it. But ultimately, the brain is changing, it is atrophying, And so it becomes harder and harder. And this is particularly important in some of the conversation we're going to talk about later, because this is not a sudden effort. By its very nature, Alzheimer's disease and dementia are insidious. They are gradual, they are cumulative, they are things that occur over the span of decades. In fact, when we think of what we know now and what's known as the JAX curve, we know the disease starts 10, 20, sometimes as far as 30 years before symptoms become severe enough to warrant a diagnosis or to warrant an inspection of what could be a potential diagnosis. And so dementia is this umbrella term to describe a range of symptoms. And as you can see there, right, Alzheimer's disease is the most common, but there are other forms like vascular and Lewy bodies, frontal temporal dementia, mixed dementias. Even there are things which could be termed dementias that are really transitory, vitamin deficiency, urinary UTIs, other things that may cause some of the same symptoms, but ultimately accuracy in diagnosis is particularly important. And as we look at the future of the disease, this idea of precision medicine tied to accurate diagnoses, personal perspectives, heredity, genetics, all of these things are incredibly important. And so when we talk about dementia, a good way to think of it is it's the umbrella, right? If we were to say flowers, Alzheimer's disease is like roses. It's one of the things that first comes to mind, is one of the most prevalent. And so, advance the slide. One of the things we look at, we talk about this potential impact, and often we look at risk, right? And so when we look at risk, age is still the largest risk factor for Alzheimer's disease. We know after the age of 65, folks are 1 in 7 times as likely to get it. Once we reach 85, it's 1 in 3 times. And ultimately, this is the diagnosis, right? So everyone has their own pathological burden. Some symptoms may be more severe, less severe, depending what areas of the brain, but age is still the biggest risk factor. Family history is particularly important. We know there are genetic factors that put people at a higher risk, that predispose them. What we know, except in rare cases of hereditary forms of the disease, doesn't necessarily guarantee, but again, it's about risk and management. And we talk about issues of health disparity and risk reduction and other things that are trending in the field. That idea of family history and heredity is particularly important. As well, head injury, lifestyle factors around exercise and diet and social activity, all of these things combine to essentially establish our risk profile. And so a lot of the times when we talk about now about risk reduction, it's about how do we mitigate some of these things to hopefully delay the onset of the disease, delay the onset of symptoms, reduce our risk. Because fundamentally right now, Alzheimer's disease is also, out of the top 6 causes of death in the country, the only one without a way to slow, prevent, or cure. And so in this world, one of the things we've looked at is a change, right? Dementia is this set of symptoms. And so I think it's important with some of the things we're going to be talking about earlier. We mentioned impairment on the cognitively unimpaired. Impairment doesn't interfere with activities of daily living. People are able to go. Maybe it takes us a little bit longer to think of a name or a word or to find our keys, but we're able to backtrack. And then we start seeing these, when dementia comes into play, it's that impairment in 2 or more cognitive functions that interfere. And mild cognitive impairment is a relatively new term that essentially is a known risk factor for dementia. So somebody has more impairment than peers in the same age bracket. But particularly important is that everyone who experiences dementia will pass through mild cognitive impairment at some point. So in fact, when we talk about prevention and protection and other issues related to health and healthcare equity, when you prevent new cases of MCI, by definition, you have the potential to prevent new cases of dementia. And so as we look at this work, just like so many other health issues, disparities come into play. When we look at all of these risk factors, it makes sense. Socioeconomic characteristics like education, poverty, and stress, delayed stress or ongoing stress, increase risk. We know that Black and African American are 2 to 3 times more likely to develop disease than their white counterparts, Hispanic Latinos as well. Certainly as we look at this and we look at the Hispanic Latino category in terms of Afro-Caribbean and other populations, there's actually a lack of data on some of this. And so these are some of the things we know that come about And despite looking at that prevalence, and we mentioned particularly the lack of diagnosis and disclosure, even in that, communities of color are even less likely to receive a diagnosis. And that is, again, as we look at this compounding impact, that's a diagnosis which may be 20 years after the disease has started. And so we talk about risk reduction and treatment and other things. It is this cumulative burden that's really hard to get by. And so when we talk about health disparities in our community, this is a particularly important topic and one which doesn't get enough attention. And so when we look at this, again, we focused on diagnosis to set the stage for some of these things. There's often questions about how and where to get a diagnosis. And ultimately, we're at a period where the National Institute of Health and the Alzheimer's Association have worked together. Some of the things you see on screen are really the best practice today. Diagnostic Alzheimer's disease includes physical exam, diagnostic tests, neurological exam, mental status tests, and often brain imaging. But we know there are inequities in access to these resources based on where people live. Even as we look at some of these things which are in common practice and research now, there are things where access is a component that is really difficult. And so if you've seen things on the news about pending blood tests for Alzheimer's disease and other components, it's really how do we do things that eliminate some of the barriers or reduce them in affordable testing ways, just like we do for other diseases. When we know the disease is starting 2 decades before we see symptoms, how do we identify these biological markers that can help us intervene? And so where we're headed in the Alzheimer's disease space is not vastly different than things we do for heart disease, right? If we test for cholesterol and we know somebody's at higher risk, we recommend interventions, whether it's behavioral or medication or others. And these are some of the things that are starting to be emerging topics, which make access to care even more important, right? For a disease which we can't prevent, cure, or slow that is ultimately fatal, access to care becomes that much more important if we can stave off the symptoms or the progression. And again, when we talk about impact to set the stage for our discussion, we know that on average, it's 4 to 8 years after a diagnosis, with some folks living as long as 20 years, particularly the earlier they're diagnosed, that we know that most folks spend almost half of their time in the most severe stages, where the disease has progressed, that they really have significant limitations on engaging in quality activities, as others would define them. And then we know all of this duration, we talked about the public health impact earlier. And we have some interesting pieces, right? Due to the prevalence among women, men are often caregivers later in life, and yet caregivers who provide the most significant time, often for male relatives, are women, providing more than 40 hours per week of care, 73%. And we have some things around cost, and I'm actually going to move quick through as we highlight some of the resources. So all of these types of things, I'd be remiss if I didn't talk about some of the things available. And so I know we have a second poll question as well, as we talk about, if you take nothing else from our discussion today, I think it's important to know that there is help specifically at every stage of the disease. 24 hours a day, 7 days a week, there are helpline specialists and others, clinicians available to answer questions, help you drive through things. We've gotten calls from, hey, I heard the latest news that says wine staves off the disease, and so I drank a bottle last week, to we're really concerned and mom isn't sleeping and we don't know what to do. Live chat's all available, language services. And as you'll see in the poll, I would ask folks is, when we talk about accessibility and a 24/7 helpline, how many languages and dialects do you think it's available in? So I'll give everybody a moment, but I'd ask you to plug in languages and dialects you think this 24-hour, 7-day-a-week service is available in. So you see we have one answer right now, or two that have us at 12. I am incredibly proud to be able to say it's actually 200 languages and dialects, so that if people reach out, that there isn't a barrier to them accessing information, being able to help navigate and have some of these initial supports. We look at other services that are just important, virtual programs, which are also in person, around the warning signs, understanding the disease, key communication strategies or conversations, legal and financial planning. And all of these are available in person, via phone, online, not just virtually live, but also on demand, so that people are able to connect when they most need help. And the same is true for support groups. And so when we talk about the impact on the community, this idea of support groups that are available for, right, African-American men and women to connect in the community where they live, or folks who have English as a second language being able to connect, those who are part of the LGBTQ community. How do we connect with those who understand what we're going through and have access to support and ongoing support, community connections where we live, where we work, where we play, and where we pray? And so I think this is important because, we set the stage for the impact of the disease, some of the things happening with it, and health disparities is a particularly important topic in this area. Just as a refresher, right? Health disparities research, or this work, is really to look at differences in population level outcomes with broad, complex, and interrelated factors, right? And so diagnosis, disease progression, response to treatment, quality of life, all of these things come into play. And often Alzheimer's disease, unlike this group, folks view it as a normal part of aging. And so it hasn't really been a part of this conversation, right? It's been something, well, we just take care of, family. We do the best we can. We have an aunt or a spouse or a partner who we provide the best care we can, but actually we're not comfortable talking about it. We're not comfortable bringing this up, even family get-togethers. I work for the Alzheimer's Association, and I will certainly share with our family's experience. We had a barbecue a few years back, and one of the things we saw, and despite not being interested in reaching out resources, we saw something was going on, wanted to talk about it. And even in our own family, it was incredibly difficult. It was interesting a few years later, really for my aunt, my auntie, when we got together, you saw some changes that happened, but also her kids were just so much more adept at handling. And one of the things I asked them, I tried not to push it, and turns out they had called our helpline. But it's all of these things that come into play. And so when we talk about risk reduction and conversation and the impact on stigma, all of these things are particularly relevant in the Alzheimer's disease space. And so I bring up a quote from one of the most well-known researchers in this world, what is a somewhat dated quote, but really looks at that, right? It's this idea of he highlights in this case, specifically around crime. The appearance of crime around Southern Blacks is a symptom of social conditions, of a stress of life. And so all of these things, particularly when we talk about prevalence earlier, right? I highlighted how African Americans are 2 to 3 times more likely. Part of the challenge we're faced with right now is we know some of those details, we know the impact, but quite frankly, the investment and the time and research and the engagement to talk about this issue hasn't been strong enough for us to start to unravel the fullness of why. And so in this work, we have another poll question, right? So all of these things, we've heard about some of the basics of the disease, some of the conditions we see, all of these types of things. And then perception matters, right? Perception is incredibly important. Access is even more so. And so you see a couple of statements on the screen, but I'd ask you to take a look at the question. What percentage of African Americans do not believe a treatment would be available to them if approved? And so take a second to answer that. We'll look at some of the other statistics here, right? 2/3 of Black Americans believe it is harder for them to get excellent care for Alzheimer's disease or other dementias. Nearly 2/3 believe that medical research is biased against people of color. And in fact, we have some astute folks on this call because over half also believe that if a treatment is approved, that it wouldn't be available to them. Think about that, right? Not only challenges in accessing diagnosis and talking about it and navigating all these complex health disparity issues, but then also when we go, we don't believe we have care. We don't believe we have access to culturally competent care, that research is biased against us. And then more than 50% of the time, we wouldn't have access to treatment. And so as we look at that, I want to highlight a couple examples. So what I have up on the screen is something called the Sprint Mind Study. Maybe new to some of us, hopefully some of us had heard of it, but essentially the Sprint Mind Study was a study looking at how do we reduce new cases of cognitive impairment, right? Mild cognitive impairment by nature, you have to go through it to get dementia. So by definition, if we could avoid mild cognitive impairment, we could reduce the risk of people getting dementia. And so that's what this looked at, right? Folks over the age of 50, again, age is the biggest risk factor. We looked at all dementias and really looked at management of blood pressure, right? We talk about healthcare issues that put us at risk. And what it found is intensive treatment, 120 systolic versus 140 systolic, had a dramatic reduction of small vessel disease on MRI and a reduced risk for mild cognitive impairment and dementia. It's the first study ever to demonstrate reduction of new cases of cognitive impairment with the potential, if it translated into the population, to keep millions of people of ever developing dementia. And so it's a really important thing, right? That's a landmark study. It's lifestyle intervention, it's intervention here, it's physical nutrition, it's all of these things. And an important component of it, so we talk about the ability to reduce risk and to do that early, have access to care, is an article not long before. So that study, we don't know if it's as relevant to our community because there weren't people of color represented in the study. When we looked at the medications used, we see things like this where some of the C medications were less effective for Black patients. And so I highlight that because as we talk about this impact, and we'll talk, we talked about the diagnosis and now research, and we'll talk about community shortly. In all dementia research, ultimately dementia research is what I would say in its golden age, right? The first case of Alzheimer's disease was diagnosed in 1907 by Dr. Alois Alzheimer. And in fact, his colleague, Solomon Carter, was one of the key folks, a person of color, who was one of the first folks involved in the team diagnosing Alzheimer's disease. But essentially, from that time until the early 80s, very little research went on. In the early 80s, you started seeing some research, particularly from the US federal government, and then funding remained flat, really for the next 25, almost 30 years. And we've seen that increase. In fact, there's been a 7-fold increase in federal research over the past 8 years. And yet, while research trials and new avenues and essentially more shots on goal are increasing, participation in non-white communities has not moved the needle at all. Less than 5%. So even the research going on now about risk reduction and prevention and others, we don't know if it translates. We don't know if those modifiable risk factors, and it's tougher to recruit, there are barriers to, and have higher dropout rates in trials. And so I give an example of what is a more uplifting idea of what's going on right now. So there was something called the Finnish Geriatric Study that looked at these lifestyle interventions and reducing risk. And as you'd imagine, it occurred in Finland, which is a relatively homogenous group, similar diet and heredity, ethnicity, race, all of those things. And so it showed incredible benefits to cognition and scoring and delaying the onset of dementia. And yet it's hard to justify if it'll go elsewhere. And so the US pointer is one of the things going on to look at this. So it's actually happening in the US. You'll see on the map on the right, 4 of the sites. There's also a site in Chicago that started up and another one coming. And it's really looking at communities where they sit, right? So in their diet locally, their activity, can we translate these things to the broader population with specific targets of recruiting African Americans into these trials so that we know if we have these things that we recommend to reduce risk or delay the onset, that they're relevant for everyone. And so here's an example of an aspect of that study, but because of timing, I'll switch and I'll give kind of the last example in the research world that I think is particularly important. So we mentioned diagnosis is difficult, that biomarkers is the future of this work, seeing the disease not upon autopsy, but being able to diagnose it earlier. In fact, a few years ago, Centers for Medicare and Medicaid Services, American College of Radiology led a study called the IDEA study, imaging and detection for the early, for some reason I'm drawing a blank here, but essentially it was the imaging tools around diagnosing dementia. And led to some really impressive results and talked about how we could reduce hospitalizations, coordinate care planning, connect families and communities on how to have better outcomes. And part of what we saw is less than 3% of people were from communities of color. And so one of the things that's actually rolling out right now, Philadelphia is one of the first 9 sites. So even folks who are willing to travel to Philadelphia, but we'd expect, well, Philadelphia and northern New Jersey, but we also expect new sites to roll out throughout the state within the next year, will be IDEA study being redone with a focus on communities of color. So that when we know things around diagnosis and heredity and other things that we're hoping will move the needle, that there's representation in that work. And then I think the final area is, we talked earlier, 53% of people think they wouldn't have access to treatment. And if folks have been watching the news, just last Monday, the FDA announced the first treatment for Alzheimer's disease in the past 20 years. And in fact, the only one that in trials is showing a benefit in improved cognition. And so today, by FDA approval, there is a treatment available that'll start rolling to the field. And it puts an urgency on conversations like this, on community building, on conversations with our physicians and our churches and others, because we are at that point where, while it's not for everybody, there is a treatment available. And so how do we engage that? How do we have those conversations? How do we make informed decisions? And I'll put the caveat is what it is, right? It's the first treatment. It's approved for Alzheimer's disease and tested in the earliest stages of the disease and mild cognitive impairment. It may show clinical benefit of improved cognition. It isn't a cure. It isn't widely available yet. Some of the biggest issues, I will say that the association's biggest priority is access to it, so that pricing and diagnosis and care aren't barriers to this, right? It is potentially too significant a benefit for too many people to have access be an issue. And so what do we do? When we talk about all of these challenges related to this disease, some of the things we started today, how do we share resources? Some of the things are part of why I'm here today, community building. Just a few weeks ago, the Black Scranton Project, NAACP and others worked with us to hold community forums. We do these regularly to hear from communities about what's working, what are their challenges, what do they need, and help build solutions together. That ultimately from the association, whether it's our work in policy or in our own work, that part of it is this idea of nothing for us without us, and that folks have to be represented in the work. And then we know, because we're on the cusp of what could be potentially life-changing interventions for those dealing with dementia, that access to research, participation in research, and ultimately too, participation in research leadership is important. And so with all of these, ultimately, our vision is of a world without Alzheimer's disease or all other dementias. But it starts with conversations like this, highlighting issues, hearing from others. And so I'm going to stop sharing my screen. Certainly, I know with our time today, with about that 40 minutes, we could certainly have spent more time on some of these types of things. But I want to see if folks have questions. Hopefully, we highlighted at the beginning that this was about highlighting some things around the impact of Alzheimer's disease, some of the resources available, some of the issues related to healthcare disparities, and some of the trends. And so that is a lot to pack into our time. When I'm sharing my screen, I don't get to see you. So hopefully I kept you interested in some of these topics. But with that, I'd open it to the group if we had any questions come through in chat, if anybody wants to unmute, or if there's anything else that you'd want to talk about this evening. The floor is yours.
Hello.
Hi, Dr. McBride.
Hey, what's up? So, well, first of all, thank you so much. That was a great talk. What do you think are some ways we could, really get more African Americans into clinical trials? That's like been a dogma that has been in existence since, since they started, experimenting on us in the past. That sort of led to this evasion to being involved in anything really. What do you think are some of the ways that we could really get people into more clinical trials so that some of these drugs could be more directed toward our needs? I think it's something that we really need to, focus on going forward in the future for sure.
Yeah, I couldn't agree more. And if I had the answer to it fully, we'd be doing everything we could, but to your point, right, whether it's often Tuskegee or Henrietta Lacks come, I mean, all of these historical issues with how we engage, how medical data is used, I mean, all of these pieces. And fundamentally, I think there's two parallel paths to it. So on a very real way, and I'll speak to the dementia space, until we saw increases in federal research funding, NIH themselves said they funded the top 10% of projects they considered worthwhile. And so I will say what that means is for the past 30 years, that the folks conducting research weren't representative of the people that needed to be recruited, right? So there's very much a piece on, are we represented in research? Are we engaged? Are we cultivating new scientific minds that look like us, that know our communities, that are representative? And there's an important component of that, just to start with, right? I think that's, how do we encourage people to go into the field? How do we offer mentorship programs? And I will say there's certain things, we just this year with the Thurgood Marshall Scholarship Fund established pathways to training and scholarships and others in this area, because it's such a need that individual organizations are taking it on to some extent, but it's still a need that, because of what wasn't done 15 years ago or 20 years ago, will be a need for the continuing. Even in terms of the mentoring side of it, there are some folks, Jen Manley and other, I mean, I could probably list some of the most well-known dementia researchers of color in 30 seconds. And I will say that part of that has meant that it is a community that connects with each other and mentors folks in an incredible way. So I think that's one part of it. I think also, as we've seen NIH funding and our funding and others increase, there's a component of mandating folks with funding to make sure they're putting in plans for recruitment that are fully represented, right? There is a piece of tying the carrot to doing this work, because no organization, no individual is going to do it. And if it's easy not to, we see what happens. And I will say that's a little editorializing. So hopefully we're comfortable with that. But there is a piece of how do we incentivize, but also hold folks accountable to it. In fact, there is a research site we talked to today that the NIH, so one of the things we work with is have NIH tying dementia research funding to some of those things. Somebody got a request back that their project is good, but there isn't a strong enough recruitment plan to include demographics that are representative of the market they're doing the research in, right? So it's not front loading or that, it's you don't have a plan to look like the counties where you're doing this work. And so how are you going to address it? And so we were talking through some of that. So I think there's some things on that side of it. Ultimately, too, I think in the dementia space, there's an overall question about stigma and conversations, but I don't think it's a conversation about research per se. Because right now there's research on, there's online research, there's really invasive research, but ultimately there's a trust component. And so there are certainly models that we know really drive benefit, right? So I will say there are a couple spots just in Pennsylvania that have embedded clinics in communities where they're there for a year in advance, just building relationships, holding input sessions, identifying community leaders, being present, recruiting folks from those communities, talking about dementia and building overall understanding and education, and then taking that feedback to help identify what are the opportunities for research. And so I think, particularly in dementia, because you have multiple stigmas attached with it, right, there is this trust building at a community level that is particularly important, which requires time and commitment that we don't often see. And it requires and again, this is not to, sometimes in the research world, it's kind of, here's our research team. This work requires a community perspective to it, that part of the extended research team has to be leaders and organizations that sit in that community, however people define it, right? I use community, and I don't want people to limit that to geography, right? It's what you define as community. If I asked each of us, we'd say, okay, well, here's my network. Here's the people I connect with my professional life. And that's it, right? There's an embedding there. So I'd start there. I think those are really important. There are certainly some models that are effective, but it's taken years. And I think it's that commitment. And there's a risk of folks helicoptering in to do that type of work, right? It becomes a priority. And so for 18 months, it's there. I think that's that is the most important thing from my perspective, and that it's not towards the outcome necessarily we want to see. I think you see a trend in funding to move towards doing this work before funding larger projects, because ultimately it's how they'll be successful. So at least it's a long answer that only touched on the tip of that iceberg, but I think some of those things are particularly important, and we see appetite and interest in that space in a way that I haven't seen. And I think ultimately there's a component about thought leadership, right? There's ultimately where folks who have power and influence decide to do this work, they bring people with them, and that's a commitment to doing it and making it. And then ultimately sometimes it's just got to show up, and you got to show up consistently. So those are initial thoughts. I don't know if that's helpful or answer. I think those are some of the things we see to there. I will say, even in that space, we have the privilege, the association just hired Dr. Carl Hill. He used to be with the NIH over their special populations, actually looking at communities of color in their engagement and research. So as I say at the beginning, I wish I had the answers. I'm really hopeful Carl will soon and help guide, but it is that one of those spaces we talk about, at the beginning, I said the Alzheimer's Association is global. One of the things is that we view this as a need that folks haven't stepped into. And so we've actually restructured our organization to start being one of the places that can try and move this needle really at a nationwide level, to try and make that sustained commitment, because that's what it's going to take.
Well, I mean, honestly, that was a wonderfully comprehensive answer. And I mean, I think I agree with you. It's multifactorial, and there's a bunch of sort of wheels and cogs in play, sort of all working at the same time. But there's been a legacy for this as well, like particularly. And I'm biased for HIV because that's what I do. But they saw changes when people, just like you said, community engagement, right? Affirmation. So when you affirm historical incidents that happen, saying we did this, how did we get better? When there's transparency, and when there's just a very good and open education regarding why things are the way that they are. And the reason that it's so important to get African Americans is we do see that there are minute differences. Fine, we're all human, so overall, all of the drugs are going to work just fine. But within ethnicity and a race, there are minute differences which may matter, and they may matter in outcome. And so if we don't know what can happen, then when we give these drugs to everyone, we don't know how the outcome is going to be, because everything's geared toward one type of person. So despite the past and everything like that, I think it's really important to at least try, and representation, just like you said, having people that come from your similar community explain things in a way that you can understand, really, really important as well. So I think you did a wonderful job answering that. You shouldn't be feel any type of way. That's incredibly comprehensive, friend.
Thank you. And I think too, it's an interesting, just in this space in particular, even once you get past that barrier, we look at things like, and I hate the term to it, but in terms of clinical trial dropout rates being higher in communities of color, there is also the piece on that some of the research going on, particularly on base science, it is improved, but the tools available 10 years ago were incredibly invasive. In some cases, they still are, but to participate in trial and confirm a diagnosis and needing functional MRIs or CSF tests and spinal tests, versus at a place now where you're starting to see in research settings, blood tests and other components being used in this. There's also some things around the field catching up, and our understanding of the brain and diagnostic tools catching up to a place where some of those things, which are very practical things that would give anyone pause, you're getting to a point where it's much more accessible in a way that hopefully helps to that. So I that's not necessarily related to race or ethnicity or anything else, but I think it's a very much barrier to overall trials in this space when in some cases you had to commit to a decade worth of trials and regular spinal. I mean, that's a tough thing for anyone to say, okay, I'm going to do that and I'm going to commit to those. And we're really seeing some of that movement change, which allows engagement over a long term or near term, just easier for any one of us.
Right. I mean, I would have run away from a lumbar puncture.
You know, yeah,
Yeah,
that's it.
that's not
it's
fun
one of those. The folks who did those and the folks who 30 years ago, 40, I mean, who had their families signing up and track, I mean, kudos to them.
Right.
And they have helped advance our understanding so much. But that's commitment. I mean, that's a big ask.
You know, I have sort of, so I just happened to, I don't know, I think I was watching something online and I do not remember the name of this drug, but I think there's like a new FDA approved drug that is questionable in its efficacy regarding Alzheimer's treatment, but it's supposed to be coming out pretty soon. And how do you feel about that one? Or how does the community feel about it?
So aducanumab,
Yeah.
now being known as Aduhelm, and in fact, the first non-research setting use of it happened today. And so from FDA approval last Monday to the first infusion for a member of the community who wasn't part of a trial setting happened today in New England. And so I think on this piece, there's an important component to it. It is the first treatment, which hopefully leads to the second and the third and the fourth. It is by nature imperfect,
Right.
but it's showing its clinical benefit in the early stages to clear amyloid in the brain. And the FDA's actual decision was that posed in a strong safety profile, that proposed a significant enough benefit to warrant approval with a post-market survey, so that they'll continue to survey it. But the fact of the benefit with the safety profile means that the potential to give families more time today is worth the approval. And so it's an accelerated approval, not different than what we've done for cancer or MS or some of those other drugs.
Right.
And so this is something we applaud, right? It needs to be done. Patients need to be informed. It needs to be done thoughtfully. It's not for everyone. Even in the trial results, I think it was like 30 to 40% of people benefited. And so an accurate diagnosis and all of that was important. But if you have a treatment with a good safety profile that has some of those has the potential for that benefit, and we're going to continue looking at what is essentially a phase 4 trial for the FDA. Association standpoint is that families need that now,
right.
and to continue to do those. And right, so whether it's early diagnosis, the safety protocols, the accurate prescription of this is there. And then we need to learn more, right? So some of the things we talked about earlier. So people of color were not particularly strongly represented in the trial. And so there's some very real things about what does that mean? Will it have, I mean, that yes, they need to occur, but the potential benefit is so significant in what is an experimental or an accelerated approval, not different than other diseases. And so it's something we celebrate, right? The opportunity to give families more time in this space and the potential to reinvigorate in terms of private investment in this field and all of these types of things. I think the biggest piece here now is there's a lot of things that go to it. It hasn't shown benefit in mixed cases of dementia. Its only indication is for Alzheimer's disease and intended to be in the early stages. So if we look at that is a percentage of people, and then it's effective in trials in a smaller percentage. And so all of that accuracy is important. And then I think one of the biggest things, and it's our biggest priority now, is access.
Right.
Right. So if you do have something that bears out, that is a treatment for a progressive neurodegenerative fatal disease, then organizations like ours need to do everything in our power to make sure the cost and insurance components of it and the access to diagnosis or diagnostic tools are not what gets in the way, right? Because this is potential to save lives. And so I think there's a nuance to it. I think a lot of the coverage I've seen is this is either a miracle treatment or it's no good and it needs 5 years more of research.
Right.
I think the right is somewhere in the middle, that there's benefit now. It's going to be in a smaller subset of cases. So the education about it is really important. But for those people who it will benefit, you're talking about a delay of symptoms that could mean months or years more quality time with their loved ones. And I think when we talk to the families we work with, they'd give anything to have that.
Right.
And now they do. Now they have some of that hope.
Well, cognitive ability is quality of life. And
Yep.
so you're helping out the patient and you're helping out the family at the same time.
Yep.
And even if it's like 5 or 10 people with anyone else who tries it with no significant side effects, that's worth it.
Yep.
And so I absolutely agree. And I think it's a good thing because they realize how much of an issue they push things through when there's an issue. They did the same thing with COVID-19 vaccines.
Yep.
When there's a big issue about it. So that's medicine saying this is a problem.
Yep.
Let's push it through. There's a good safety profile and let's use it for people who meet the indication. So
Yeah.
wonderful. Well, I mean, I got to tell you, I will let you have a moment to breathe and we can potentially end and out. We can switch over to closing remarks for sure. But this has been a fantastic talk. It was edifying to me, honestly. And thank you so much for being here for sure.
I appreciate it. And just thank you to each of you in the BOLD ERG and everybody who joined us today. All of what you're doing this month is so important. And I know the first round too, it's said earlier, sometimes to show up and highlight what we think is important. You're doing just that, and just glad to be a small part of that. So thank you.
Awesome. Thank you.
Can everybody see that?
Yeah.
I'll be quick. But yes, thank you so much for coming, Mr. Jacobs. We really, really appreciate it. It was a great talk. Personally, I have family who have family history of Alzheimer's, so all these resources that you've given us is really amazing. I just wanted to highlight that we do have a couple more speeches coming up for the month. I think we have 2 left, plus our journal club on Tuesdays. Please register for whichever event you'd like to join. I know the journal clubs have been really robust conversations happening, so we really appreciate everybody's participation. Like Mr. Jacobs says, we really find all this information to be important and valid and something that our community needs. So thank you for joining tonight, and you guys all have a great night. And thank you again, Mr. Jacobs, for coming.
Thank you. Have a good night, everyone.
Thank you. Thank you.
Thank you.
All right.
Are you done now, Dr. McBride?
Oh my God, hopefully. I'm gonna do this one last thing and then I'm rolling out of here. I have a grant to finish too. So.
Oh, yes, sir.
But oh my goodness. How is everything going?
Everything is good. Hold on, let me stop sharing. Everything's good.
Stop recording too. You could stop
I'm a
recording.
little sad that Dr. Sapp's leaving us, but
No.
but you know,
Face.
I'm happy for her. I'm glad she got her position, and
That's what happens when people don't appreciate you. I mean, I can't be mad. Like that's what happened. You want me to hit stop recording?
Oh, I can do that, yeah.
Okay.
That's all me. Oh no, maybe it's you.
Yeah, I can send it to the cloud.